Good afternoon, everyone. This is Dave Iverson, the contributing editor at the Michael J. Fox Foundation for Parkinson's Research and the moderator of today's webinar. Thanks, everyone, for joining us. As many of you know, this is part of our ongoing series of Third Thursday webinars that take place at 12 Eastern, 11 Central, 10 Mountain, 9 Pacific on the third Thursday of every month, where we'll take up a question or topic that's of particular interest to the larger Parkinson's community. So we hope you'll continue to mark your calendars over the course of the year and be able to join us. As always, you'll be able to submit questions throughout the hour, and we'll do our best to answer as many of them as we can. You'll see a little Q&A box on the right of your screen, so just type your questions in there, and we'll start taking those about halfway through our session today. And if we don't get to your question, as we certainly may not because we have thousands of people who are joining us today, we also are going to have one more Q&A opportunity tomorrow on Twitter. So at 12 Eastern tomorrow, if you use the hashtag FoxPD chat, we'll continue this conversation on complementary and alternative medicine. Dr. Rachel Dolan from the Foundation staff will be online during that time, and we'll be able to take more of your questions then. And then last, before we get started, just two other quick notes. The slides from today's webinar are available for you to download. You'll see a box called Resource List on the right, and you'll be able to click there and download the slides as well as some additional resource documents that you'll be able to save or print. And then we also want to make sure we also thank our sponsors of our Third Thursday webinar series, Acadia Pharmaceuticals and Fava. So let's get started and talk about what we are going to cover today on our webinar about complementary and alternative medicines here in Parkinson's disease. So here are some of the topics that we want to be able to cover today. We want to be able to talk about the various things that are involved in this topic, including what we want to do with a variety of topics, as we'll wait to get our slide up here on the screen. Here are the things that we're going to be covering today. So what do we actually mean by this name of complementary and alternative medicine? What's involved in that? What are some of the practices that can help manage Parkinson's symptoms outside of the normal ones that we think of more of a pharmaceutical orientation? We're going to talk about what the effects of both nutritional supplements as well as diet and what those kinds of things can do if you're living with Parkinson's. And then we want to get into this really interesting question of why is it so difficult to actually determine what the effects of various alternative and complementary approaches are. So we're going to talk some about what some of the research challenges are in this field. Let's meet who's going to be joining us in our conversation today. Here are our panelists. Gary Vallat is joining us from Whidbey Island near Seattle in Washington State. He was diagnosed with Parkinson's in 2008 at the age of 65. Very interested in complementary and alternative approaches, tracks how each of them impact his ongoing journey with Parkinson's. He's also someone who's very active in his community in a variety of activities, everything from various volunteer activities to sports and singing. And Gary, thanks very much for being part of our conversation today.
Thanks, Dave. Thanks for inviting me.
Happy to have you join us. Joining us as well is Dr. Danny Bega. He is an instructor in the Department of Neurology at Northwestern University Feinberg School of Medicine. Also recently completed a study on the impact of yoga in particular on Parkinson's. And Dr. Bega, thanks for being part of our conversation as well.
Hi, Dave. Thanks for having me here. I'm really excited to participate in this discussion of such an important topic.
It is an important topic, and we're really glad to have you join us, as we are also Dr. Laura Mishley. Dr. Mishley is someone who has a doctorate in the naturopathy, also has a master's degree in public health, and is a research scientist at Bastyr University Research Institute just outside of Seattle as well. Dr. Mishley, thanks for being here too.
It is a pleasure to be on this call.
So let's dig right into our topic and what's involved in this topic. So we first want to raise just this question, well, what do we mean by this term? What do we mean by the term complementary and alternative medicine? And unfortunately, as you'll see in this next illustration, it's not perhaps what some of us would most wish for. Unfortunately, alternative and complementary approaches do not include pizza or chocolate recommendations for lowering our cholesterol. So while we might like that, doesn't seem to be that that's actually part of the story. But here's what the story actually is. And what we mean by that is that these are approaches that differ from standard, perhaps more pharmaceutical or surgical or medical practices. Complementary tends to mean those that are used together alongside of and in addition to standard medical care. Alternative, we're thinking of more practices that are done instead of a standard medical care. And just to sort of tease this out a little bit further, Lori Mishley, I know what's beginning to be thought of, and Danny Bega, you can join in with this thought too, is to use the term sort of integrative, because I know, Lori Mishley in particular, you have some feelings that we shouldn't think of this as an either-or divide.
No, I think that what we're seeing more and more is this hybrid between, as medicine evolves, we're starting to learn from one another. And, you know, vitamin D used to be thought of as complementary and alternative. Probiotic supplementation was CAM a few years ago. And as we're learning from each other, I think we're realizing that it's not about conventional and unconventional. It's whatever works. So what is unconventional is only unconventional until people come around to realizing it is efficacious, and then we start using it. So this divide actually creates a barrier.
Yeah, I agree with that exactly. You know, the definition used to be for complementary and alternative medicine used to be that it was all those things which we don't learn about in medical school and which insurance companies won't pay for. And obviously that's a terrible definition. And as things become more evidence-based, they start to fall within what we consider conventional medicine. But I think it's more important to focus on what unifies the different CAM modalities or the complementary modalities, and that's, you know, features like focus on wellness and on the whole mind and body together, focusing on the individual rather than focusing on the disease, focusing on the body's ability to naturally heal itself, focusing on empowerment. I think these are things that define complementary medicine a little better, and I think that the term complementary and integrative medicine is starting to be used more and more for that reason.
So let's take a look at some of the individual components then of what this approach can include. So as we'll see on the next slide, there are various domains that can be considered as part of this broader topic. Everything that are more biologically based approach, which include things like diet and herbs and vitamins. Things that are somewhat more physical, such as massage or chiropractic kind of care, mind and body interventions, such as yoga and meditative practices, and so forth and so on. And we're not going to really, we won't be able to cover all of these, but this slide is to kind of give you a sense of the various things that can be involved in this. But I want to spend a moment here before we start digging into the individual parts of this and talk about what is appealing about this. Danny Bega outlined some of those things, a focus on the individual, a focus more on wellness. But Gary Vallat, from your standpoint, as someone who has dealt with Parkinson's now for the last 7 years, what drew you to this more integrative sort of approach in your own journey with Parkinson's disease?
Well, I was always looking for things that I thought could contribute to my well-being. And fortunately, I was put in touch with Dr. Mishley. Through conversations with her, I began to appreciate a lot of the opportunities that complementary and alternative medicine bring to the table. And so I tried these, and I found that, in fact, I had some things that actually indicated that there was benefit from using these particular practices. I know when I first I started doing acupuncture, my wife, when I came home, she said, "Wow, you look so much more alive." So I think what happened is that there were some immediate responses to the treatment that were encouraging. And so I just continued to to consider the options and opportunities and try them out, and then try to assess the impact they have on my particular condition.
And in a moment, we're going to go into one of the things that you've been involved in, and which includes just being very, as you have put it in a prior call when you and I talked, being more kind of outwardly oriented and being engaged. And we're going to get to that in just a moment. But since you brought up the word acupuncture, and we've already had a couple of audience questions about acupuncture, let me just ask that question, because what's often it's true actually with any form of treatment of Parkinson's, what's difficult to know sometimes is, well, what do we know and what do we not know? What do we know about what works? What do we still not understand about what works? So let me ask that question when it comes to acupuncture, Danny Bega. What do we know about its efficacy in dealing with Parkinson's?
So acupuncture is one of the better studied of the complementary modalities in Parkinson's, and still not that well studied, but there have been 5 or 6 reasonable sized studies, some of them even with placebo controls, which are important when we're doing research in general, because it raises your level of confidence in what your outcomes are when you have one group receiving a treatment and one group thinking that they're receiving a treatment but not really receiving it. And there have been mixed results with acupuncture. I mean, safety has been demonstrated repeatedly. It seems to be safe, and seems to be safe in Parkinson's. In terms of actual effect on mobility, on rigidity, on tremors, kind of a mixed bag in terms of what we've seen. Some studies showing some benefits, other studies showing no benefits. The better designed studies, those with the placebo control groups, have shown less impressive benefits, which calls into question whether some of the benefits in the other studies were just this placebo response. The effects are mostly seem anecdotal. People will describe benefits that we don't necessarily see when we measure outcomes. When we measure mobility, it's less impressive than when we ask people how they feel, where they often do describe benefits. And so that calls into question whether our measures are good enough to capture the benefits that people are getting from the acupuncture. But most of what I've seen is short-term benefits. I haven't seen anything looking at long-term effects of people getting acupuncture, if that actually makes a difference in terms of their disease course. I have seen reports of short-term benefits after the acupuncture is done.
Yeah,
and Gary Valid, what would you add to that from your own personal experience in terms of what you've at least sensed have been the benefits of acupuncture?
Well, I was fortunate enough to be put in touch with Dr. James McNamara at Oregon State University. He works for a company called APDM, which has motion detectors, motion sensors. And I've been wearing a device for almost 2 years now, recording all the movements of my body. And then he parses that data and actually can parse out tremor from full signal load that the device is capable of measuring. And when I look
That's right. That's exactly what I'm talking about, actually. With our measures, may not be good enough to capture it, and the kind of sensors that you're describing may be finer in terms of capturing the benefits.
Well, and what came out of that was that when I'm on the table, you can see a marked change in terms of my tremor. But I think that's just because I get very relaxed on the table, and my tremors tend to abate and go away when I sleep or when I'm really fully relaxed. Same thing happens in a sweat lodge, for instance. So
fascinating. And Gary, if we might, could we just want to ask you, a few people are having a little bit of a difficulty hearing you. So if you can project a little bit more, if possible, that would be helpful for our audience. Let's transition into our next slide, because that'll actually kind of broaden this conversation out a little bit more about this aspect of complementary and alternative medicine. And that has to do with meditation, yoga, and importantly, I think other activities that engage you in kind of the world around you. And we can see listed on the slide here a variety of impacts that these kinds of practices can have. And Lori Mishley, let's pick up on what Gary was just saying, which is that these more first, it's interesting that these more sensitive wearable devices can help measure these more subtle effects. But he also made this interesting point, I think, about just relaxing. And management of stress in some ways is also helpful. What do we know about that part of more meditative practices or approaches and how that affects contending with a disease that can be both stressful and can make muscles in particular sort of stressed and rigid?
Yeah, I don't think that we know a whole bunch about the muscle stress, but I do know that every patient will tell you that when they're stressed, their symptoms worsen. And so, there are decades of research showing that meditation and yoga can help relieve stress. I think Dr. Bega's onto something with our lack of fine tools that will measure these things. There's a really interesting study that came out recently talking about this thing called heart rate variability. Being correlated with your non-motor symptoms. Non-motor symptoms are infamously untreated by conventional therapies. This is the dizziness when you stand up, bowel issues, saliva issues. And recently somebody showed that this lack of heart rate variability is associated with non-motor symptoms in Parkinson's disease. And that for me was a really exciting lead because we have probably 40 or 50 studies that say, hey, when you do Tai Chi, when you do yoga, when you meditate, it improves your heart rate variability. And so I think we are evolving into this world where technology is catching up with what patients have been telling us.
And that whole question of the wearable technology, right? The Fitbits or other apps that are now maybe give us not only more sensitive data, as Danny was suggesting, but more continuous data. So it's data that can be collected on an ongoing basis, and that may give us a kind of rounder picture. Is that part of what we need, Lori Mishley, a kind of a broader sense of really what's going on in everyone's everyday life?
It is, exactly, but it may not come from technology. We're working on this really neat outcome measure that we will probably be publishing in the next couple months, but it's a patient-reported outcome measure. And what we're learning is we ask patients about 33 different questions, and we ask them, how are your bowels? How is your handwriting? How is your sleep? And what we're learning is patients are actually better at assessing the severity of their disease than any of the scales or tools that we have. And so as non-technologically advanced as it is, what we may have been neglecting all along is just simply turning to patients and asking, how are you?
Let's find out a little bit more, if we can, about yoga in particular, because that's one of many activities that just from a common sense standpoint would seem to make sense when you're living with Parkinson's, the kind of stretching that it does, kind of relaxation that may be achieved. And Danny Bega at Northwestern, this is something that you've looked into. Tell us what you found.
Yeah, so we did a small study. We had about 20 participants, all with Parkinson's disease, and half of them did yoga twice a week for 12 weeks, and the other half participated in more conventional exercise, resistance-based exercise with weights. And what we found was we were looking at both the motor and the non-motor outcomes because this disease does, as Lori mentioned, affect both mobility, but also a lot of these other non-motor issues like blood pressure and cognition and mood and other things. So we looked at both motor and non-motor outcomes both before and after the 12 weeks. And while it was a small study, so it's hard to make big generalizations about it, we did find benefits in both groups. We had already known that regular conventional exercise is beneficial, so that was no surprise. But seeing similar benefits in our yoga participants was encouraging, both in terms of their mobility outcomes, but also actually in certain cases even more benefits in some of the non-motor outcomes, which you might expect, like mood, quality of life, anxiety, sleep. So suggesting that definitely bigger studies are warranted to look at some of the effects of yoga.
And Danny Bega, Deborah is raising a question, and we're going to get to more of your questions in about 10 minutes, but I'll slip this one in right now because it's on point, which is, does it have to be a particular kind of yoga for people with Parkinson's?
Well, the type of yoga that's typically done is the Iyengar Hatha yoga, just because it's a style of yoga that's a little easier to do and that can be adapted to people with different needs and abilities. You can use props, you can use chairs, And so it's a little bit more suitable. Not that that's necessarily the best kind, but it's just a little easier to use. The one kind of yoga that I think probably should not be used is the hot yoga, only because a lot of people with Parkinson's do get blood pressure issues, can get lightheaded, can get dizzy, and so that's probably best to avoid. But there haven't been studies showing one type of yoga be more advantageous than another in Parkinson's.
And before we move into some of our dietary and nutritional questions, which I know are top of mind for many people, I want to ask both Gary and Lori just a little bit more about one other aspect that's mentioned on these slides. And Gary Vallat first, and then Lori, I'll come back to you. We see on that third bullet point things that encourage personal empowerment. And the next one, activities and socialization that discourage isolation. And Gary, comment on that as someone who's involved in everything from sports to singing to various volunteer activities. I know part of what you feel is that when you have something like Parkinson's that can sort of be isolating, it's that much more important to sort of be outwardly oriented. Say something more about the importance that that's had in your life. And then, Lori, I want to draw you into the research that you're finding along those same lines.
Well, I think for me it's important. And when I look around at some of my friends who have Parkinson's disease, I find that there is a tendency sometimes to withdraw. And I experience that myself. You know, if I'm having not a particularly good day, the tendency is to kind of curl up in the corner. And if I find that I have meetings scheduled for that day or that I've made a commitment to meet with a friend, it simply pulls me out. It means that the disease is more behind me and I'm in front of it, finding my way through my life. I do a lot of volunteering, and that gives me a sense of connection to my community. It gives me a sense of being pointed outward rather than being lost in the disease. I have more of an outward orientation towards relationship and community. So I'm in groups, discussion groups, and I actually have a poker group, which is good as fun.
Good medicine.
So I can make a little money on the side. And then I also like to play ping pong, and I find that keeps me moving. So I think those things are positive in terms of keeping myself pointed outward and moving. I have a physical therapist, and I also have been doing some resistance training for strength, and I'm finding those to be really beneficial in terms of just a feeling of physical well-being, of strength and confidence. So I think all of those things tend to turn around some of the natural proclivity that's involved in the disease itself.
They're great points. And Lori Mischli, it also, I know, underlines something you're discovering in your own research. You mentioned a moment ago this idea of patients being the best experts about what's going on with them. And in the online data that you're collecting from some 750 people living with Parkinson's around the globe, I know you mentioned the other day when we were talking that one of the key, and this I find fascinating, predictors of how well people are doing has to do with the word loneliness. Would you expand on that a little?
Yeah, so, people always ask in my private practice, if I get good results. And one of the things that I've said from day one is that I have an unfair advantage because the people who walk in my office are already empowered to a degree. They've already begun to look at their options. What else is out there that my conventional physician may have not known about, not told me about? What are my options? So when people come in, they're already ready to roll up their sleeves and say, what can I do? And I really do think that is a tremendous advantage to the patient because they're engaged. And so based on some Alzheimer's research I had read and this sense I had gotten from a decade in practice, when I designed this survey, it's called CAM, CARE, and PD, and we're looking to find out what are the variables associated with those individuals who are doing best. One of the things I wrote in there was a little true-false question that says, I am lonely. And, I designed the study hoping to get some answers about dairy and blueberries and carrots and things like that. But I have been blown away that really one of the most profound pieces of information that's emerging from this entire data set is that the people who are doing worse of everybody are the people who say, true, I am lonely.
Yeah.
Can I add something to that?
Yeah, go ahead, Dan.
I'll say that from my experience with patients, the patients that are like Gary, who come in with that motivation and involvement and pushing themselves out of that sense of wanting to kind of go inward, those are the patients who do better over and over again, regardless of what they're coming in with in terms of symptoms. And we've seen this in studies that have been going on for years and years and years, where we look at what affects quality of life in Parkinson's the most, and it's over and over again. It's not tremor, and it's not walking, and it's not stiffness. It's anxiety, it's depression, it's these non-motor things that that probably more than anything the patient has more control over than the physician, and so I think that mentality is why certain people do better than others.
It's really worth underlining, I think. Go ahead, Lori.
Well, I was just going to add that I think we're emerging, this idea is switching, where I used to think of support groups as a tool for coping, and I've begun to think of support groups and that kind of participation as part of the medicine.
Yeah, yeah. I think that's a great distinction, because too often I think we sort of think of this as stuff that would be kind of nice to do when it may actually, be closer to being necessary to do. It's not unlike exercise. We used to think of that as sort of, oh, yeah, it's nice if you exercise, but we're learning that indeed these things are crucial and as important, if not more important sometimes, than the things that we think of as being the necessary parts of medicine. But Laura, you mentioned a moment ago that you went into this study thinking you'd find out more about questions that have to do with nutrition, and so let's move into that, because that is something that's top of mind and lots of people have questions about. So let's move our discussion into the question of dietary supplements and nutrition, and we'll talk first about dietary supplements, because there's always lots and lots of interest about this. And as you'll see on this list, one of the points that we wanted to make in this webinar today is that, in essence, just because something is natural doesn't mean that you should proceed kind of casually, that we need to sort of think about these things and their impact precisely because they have impact. That means we have to talk about them with our physicians. We have to think about the way in which they may interplay with other medications that we're taking, and that because this is a disease that is so varied, we can't. We have to make sure that each part of this fits each individual. Danny Vega, let's talk about a couple of things, and then I'm going to come to you, Lori, on the great coenzyme Q10 question. But before we get to that, recommendations. What do we know about nutritional supplements? I know that you think some vitamins, for example, are particularly useful in Parkinson's. Mention what some of those are.
Sure. So I think from a standpoint of what do we know from actual evidence, we know very little, actually. We have a reasonable amount of animal data showing that certain things like spices, like turmeric, maybe potentially slow down the deterioration in the cells in animals, in rats, in mice that have Parkinson's. We know similar things have been shown with things, as you mentioned, coenzyme Q10 and creatine and vitamin E have been shown in animals to be effective. But there's a difference between animals and humans, as you all probably know. And when studies have actually been carried out in humans, they've been somewhat disappointing. And so what I typically recommend is what we know to be a healthy diet. In general, a healthy diet for anybody, but with a little bit of focus on some of what we know is causing the deterioration of Parkinson's, which is we know that to some degree there's some inflammation going on in a certain part of the brain that causes the cells to degenerate. We know that there are unstable molecules called free radicals that kind of float around and cause damage to cells. and the idea of antioxidants that bind these free radicals that protect the cells may be protective. We don't, again, have any evidence in humans that these things make a difference in Parkinson's, but based on our understanding of what causes the disease and based on what we've seen in animal models, it makes sense to try and have a diet that's high in antioxidants and low in inflammation. And so some of the things I recommend are, the kind of good fats to eat, what kind of colorful vegetables and fruits should be eaten. But basically anybody who were to use this diet, it would be a beneficial diet for anybody. And because it's not evidence-based, I still feel comfortable recommending that to patients because it's healthy. Yep.
Sorry to interrupt, but we're going to put up in just a moment a slide that lists a lot of those different things. So I'm just going to ask you to hold on some of the dietary nutritional diet recommendations and just focus for a moment more on the supplement question, because people often want to know what they can add to that diet. And Lori Mishley on the coenzyme Q10 question, which is something that was extensively studied a number of years ago, and a lot of people had high hopes that it might be something that would not only be perhaps of symptomatic benefit, but even slow down the progression of the disease. Pulled the plug on the study, National Institutes of Health did, because there just wasn't the evidence. This we'll get into a bit later when we talk more about some of the research challenges. But I know one of the things that you wanted to note about this, and this has to do with the way in which we all are varied. It may well be true that coenzyme Q10 doesn't work for everyone, but there actually may be some people for whom it could be helpful.
Yeah, I think in my mind the CoQ10 story is that's still a question on the table. I mean, we have to remember that large phase 3 study got funded because there was a lot of data leading up to it that suggested coenzyme Q10 may have some benefit. And the only study that has been really negative was this last huge, large one. And so before we say, hey, that the final study ended the story, I think we should just make sure that we ask, are we sure there wasn't a problem with how that study was executed? And it had a great team of researchers. It was a well-conducted study. My question, and what I had said to you during our podcast, was, there's a little bit of research out there that says 30% or so of people have coenzyme Q10 deficiency. I did a study a few years back using this one particular blood measure called FIA. It's a functional measure of coenzyme Q10 deficiency. It's how we measure a lot of nutrients in research. And according to this small study, 30-some% of people with Parkinson's have CoQ10 deficiency. And in this coenzyme Q10 study, what we did is we didn't use that test. We just took a whole bunch of newly diagnosed people with Parkinson's and treated them all the same. And what I was wondering is, did we dilute our results by 2/3? What would the results have been different if we had just asked that question among the people deficient? Do they benefit if they get coenzyme Q10 or not? I think that's one big question just in terms of how we evolve study designs, getting better at finding those people who are most likely to benefit from the intervention. And then along the same lines, I think that when you step back, it's not just an issue for nutrients, but everything that we have attempted to study for disease modification has failed the way we're doing studies. And this is a big conversation happening, among researchers. But one of the things that we do is we restrict disease modification trials to people who are not on dopamine. And it is a convenient way to interpret the study. When being on different medications certainly muddies the waters and it makes it harder to interpret the study. But if we know that the brain needs dopamine to function and we know that people aren't getting enough, it doesn't make a lot of sense to continue to restrict people's access to something we know they need and then give them something else and see if it makes everything better. So I think what I would love to see as we get better at doing research, whether it's for complementary and alternative medicine or conventional therapies, are study designs that are more pragmatic. I mean, 80-90% of people with Parkinson's are using dopaminergic therapies. If we're going to study something and ask, hey, can this make a difference in your course, it would be nice to study people who are study a population that is reflective of the people we're trying to help. And I have this analogy I use about, having a couple leaky holes in the bottom of the boat. if we're going to make a big difference, we have to plug them all. We can't just plug one and see if it stops the problem. And so I think of the dopamine hole as one major deficiency. Maybe the CoQ10 is another hole. Maybe there are a couple others. But as we get into this holistic, integrative approach to medicine, I do look forward to a day in research where we plug all the holes in the bottom of the boat and ask, did that help?
Right, and I think as important is this question you're raising, which is it may not just be one question, what would slow disease progression? It may be that what slows in Gary Valla is a different question than what slows disease progression in Dave Iverson versus the 2,000 people who are dialing into this webinar today, because each of us may be deficient in one area, and something that might supplement that would slow disease progression in our case, though not necessarily in the person next to us with Parkinson's, just because, as we know, it's such a varied disease. Let's push on to our next slide, if we might, and we'll talk a little bit more about dietary questions and start feeding in the various questions that you've raised as well. So if we can take a look at the next slide that spells out the various things that have to do with our diets, we can start digging into a little bit more information about that. So we see a big list here of all kinds of things, and Gary Valla, Danny Bega has already mentioned the importance of antioxidants and anti-inflammatory foods. Before, Danny, we get to go through a few more of these, I want to bring Gary Valla back into our conversation and just ask for his sort of personal experience with this. Have you found, Gary, that modifying your diet in a particular way has been helpful in the way in which you've dealt with Parkinson's?
Well, that's kind of a difficult question, because there are a lot of factors that enter in, and it's sometimes hard to tease them apart to figure out which one is the most responsible agent. I certainly try to pay attention to these things like diet. We eat local organic greens and vegetables. I don't think there's anything there that's going to damage me or exacerbate my condition. I have a no gluten diet, and that's out of curiosity, because I think there's some good information out that I've read leads me to believe that could be efficacious. I also try to reduce sugar in my diet. Those things seem to be generally accepted, beneficial things, whether I have Parkinson's or not. It's good to not have a lot of sugar in my diet, for instance. And it's good to have some antioxidants in my supplement list. I've been doing glutathione for about 4 years, and even though I can't compare it, I can't really establish that there's hard results for me. I think there's research that Lori's doing that would speak more to that. But it's something that I include in my day-to-day practice because I think there's promise. It is an antioxidant, and I can't find that there's any deleterious effects from it.
Well, this is an area where I think it is really hard to tease out, what's having an impact and what isn't. And as you're both suggesting, both you and Danny Bega are suggesting, there may be some things that are just sort of good general practice, whether you have Parkinson's or not. But let's get a little more detail on some of the things that are listed. We'll come back to glutathione in a moment. But you've mentioned, Danny Bega, a couple of things that are helpful: antioxidants, anti-inflammatory foods. Talk a little bit about the not so helpful things. Gary just mentioned sugar in particular and dairy. Why are those things that potentially, at least, people with Parkinson's might well have a more cautionary relationship to?
Sure. Well, again, it's not necessarily just people with Parkinson's. It's pretty much everybody should really stay away from, simple carbohydrates that are basically sugars, like bagels and pasta and desserts, and hydrogenated oils and red meat. All of these things are pro-inflammatory. I mean, we know that these foods produce inflammation in our bodies, and what we don't know is whether that translates to the inflammation that causes the damage in Parkinson's. Although one could easily make that leap, it would make sense. We don't have that data, but it makes sense to reduce that by avoiding those foods in case that does impact the inflammation in the brain as well. I think it also improves energy level. Just having a healthier diet that avoids those foods will improve energy, and low energy and fatigue is a big problem in Parkinson's as well. And so I think that translates to feeling better also. You mentioned dairy. I would just say not all dairy is bad. certainly, high-fat dairy can be more inflammatory. Some dairy, is useful because it has vitamin D in it for bone health is important, especially if in terms of fall risk and fractures. So having some dairy in the diet is good, but maybe not just the high-fat dairy.
And Lori Mishley, Gary mentioned glutathione, which I've heard kind of both things about, that it can be useful, others saying really there's no evidence to suggest that. Where do you come down on that?
Well, can I say something about the diet before we move on to the glutathione topic? I just want to draw a distinction between the research that we know. There have been about 5, 6, 7 studies that really look at tens of thousands of people and ask, are there any dietary factors that increase your risk of developing Parkinson's? Which I realize is a very different question as from does it shape progression. But we do know that, fruits, vegetables, beans are very protective, fish is protective, and there have been 5 studies now that say, are there any foods people eat in adulthood that increase your risk of developing Parkinson's? And all of those studies have identified dairy, not yogurt. Yogurt has not been associated with an increased risk, but especially the creams and milks do seem to increase risk. And that doesn't mean once you already have Parkinson's that it's going to accelerate your disease, but it does beg the question, is there an environmental issue there? Is it the pesticides in the milk? Is there something in the dairy? Is it doing something to our guts? So, and then, in terms of this idea of nutrient density, I think the other thing I just want to make sure that we talk about is that, Dr. Bega mentioned the antioxidants and the fiber. I think that's all really important, but we cannot understate the importance of the intestinal microbiome. We are now realizing, 80+% of the immune system function is controlled by the bugs in our intestine. And I think what we're realizing is the more plant-based foods you feed those bugs, the healthier the strains of organisms that grow and the better your long-term immune system function. And along these lines of inflammation, there's some really interesting data out there talking about abdominal obesity being associated with microglial activation in the brain, which is something a lot of researchers are interested in right now. And that's something that's really fairly easily modifiable. So when we're talking about these foods that provide calories and take up space without offering much nutritional value, it might be a good idea to get rid of some of those. And if you have a few extra pounds around your waist, target that. That's a very effective strategy that looks like it may translate to brain health.
All good points, and as always, difficult sometimes to tease out what's causation and what's association with some of these things. I'm reminded of the fact that, caffeine or certain other things that people who smoke are also associated with less likelihood of getting Parkinson's, but for obvious reasons, some of those things can be problematic too. Let me bring you back, though, to the glutathione, Pone, if I might.
Yeah, sure. So about 35 years ago, we started looking at brains of people with Parkinson's disease on autopsy and realizing that there was a deficiency of the brain's primary antioxidant. It's called glutathione. It is responsible for the vast majority of antioxidant function in the brain, and it's used all throughout the body. And what we have learned over the years since is that in animal models, in test tube experiments, when you get low in glutathione, you have mitochondrial dysfunction, free radicals, ultimately loss of dopamine and cell death. And so, going back 35 years, people said, hey, if glutathione deficiency leads to a whole bunch of these problems that we see in Parkinson's disease, and people with Parkinson's are low in glutathione, maybe we should be giving glutathione. The problem with that is that it is not orally available. So it has not been that easy to augment glutathione and do these studies and trials. In '96, some Italian researchers did a very small, unblinded study with maybe 9 or 10 people, and they gave intravenous glutathione twice a day for 30 days, and they reported a 42% reduction in Parkinson's symptoms at the end of the trial, and they said that those benefits lasted for a couple months after the trial was over. What's really interesting is if you pull that original study, they actually compared it to levodopa, and glutathione had as good, if not better, improvement in Parkinsonian tremor using what they were calling a tremogram, one of these motion sensors. And so nobody really followed up on it much after 96, and then David Perlmutter started popularizing this online and posting YouTube videos of him giving IV glutathione to patients who were getting quite a bit better very quickly, and that created a lot of demand among patients for glutathione. And so Dr. Hauser and David Perlmutter and a crew in Florida published a very small pilot trial of intravenous glutathione a couple years ago, I think 2009, where they gave IV glutathione 3 times a week. And they concluded it was safe, it was tolerable, more research should be done, and there may have been a small therapeutic effect, a symptomatic effect. I'm on my 3rd trial right now of intranasal glutathione. We started using this about 10 years ago in clinic because there were some ear, nose, and throat docs using intranasal glutathione for sinusitis. And so I didn't think it was appropriate to be giving IV glutathione. I thought the risks and the cost were not worth, given the state of the science, I thought it was a little premature to be doing IV glutathione. But intranasal glutathione was something that was much less expensive. People could do at home, and a couple patients started trying it and having really good results. We got a study funded through the National Institutes of Health. We concluded a phase 1 safety and tolerability study last year. And we concluded it is safe, it is tolerable, and we were really surprised to see it actually did result in some clinical benefit. It was not the goal of the study, but it was certainly something that we saw. So based on those results, Michael J. Fox Foundation has funded 2 follow-up studies, one using MR spectroscopy, where we spray glutathione up people's nose who have Parkinson's disease, and we can see it getting into the brain. So we now have target validation, and starting next week, we will be starting a phase 2 follow-up study trying to really hone in and clarify what are the clinical effects. What we really want to know is, can we slow disease progression? Yep. Is there some neuroprotective potential? But the curveball here is the symptomatic effect.
Let me hold you there. It's fascinating stuff, and it's great to know that more research is going to be done, because it does sound intriguing and promising. But we have lots more questions I want to get us to, so I'm going to move us away from that and get to some other things that have come in. We're going to get to the questions of magnesium and mucuna in just a moment. Lots of people raising them. Before we get to that, though, very briefly, if you would, Danny Bega, a number of people are asking about beans and fava beans in particular. Can you just give us your bottom line on that question?
I mean, I can combine that with mucuna, actually. I mean, these fava beans and mucuna are natural sources of levodopa. They do contain levodopa, which is the precursor to dopamine. And so it makes sense that taking them would increase the dopamine and improve some of the symptoms. And there have been reports of people describing improved on time with their medication after eating fava beans. Certainly, mucuna can cause effects similar to Sinemet, to carbidopa-levodopa on motor symptoms.
What is that exactly? Can you describe what mucuna actually is?
It's a legume, and it's an Indian legume, I believe, but it's got a very interesting appearance to it. If you just look at a picture of it, it looks like a plant, but it's actually some kind of legume. And so both the beans and the mucuna, they're a natural source of levodopa, but that doesn't necessarily mean that they're better than the synthetic carbidopa-levodopa that we make. So it goes to your point of not everything natural is necessarily better. The issues being we don't know as much about how well they penetrate into the brain, and also how to adjust doses and the way we can with conventional medicine in this case. And so it's hard to say that there are any added benefits to being on mucuna or taking fava beans over taking the medication. Like I would expect, and they've been described to have similar actually side effects to what you can get with Sinemet, because it really is a very similar product, but it's not under FDA regulations, and it's harder to adjust. So I have had patients come to me on mucuna, and if they have actually dyskinesias as an effect of too much medication, I don't really know how to adjust how much mucuna they take to make them feel better other than to tell them to take a little less. So it can become complicated and difficult, and I don't know really that it's necessarily better than the synthetic. With fava beans in particular, people need to be careful, especially people of Mediterranean descent, because there is something, a rare problem called Favaism, where you can actually get a hemolytic anemia. Certain people who have a susceptibility to it can get an anemia, which can be life-threatening, although that is rare, something to be aware of. So not everything natural is always safe for everybody.
And is that also the case that a lot of people are also raising the question, Danny Vega, about marijuana, which, again, I think there's interest in the research community about what might be beneficial within marijuana, but it's also something where it's hard to tease out what the specific part of marijuana might be that's of benefit. And the dosage question is also really a tricky one, right?
It's very tricky with marijuana. I mean, the interesting thing about marijuana is that it's actually the receptors for cannabis are maybe the second most populated receptors that we have in our brains, because we make our own cannabis. And so, the potential for effects on all different parts of the brain are really robust, and particularly in areas involved in Parkinson's. I mean, there's reasons to think that cannabis would have benefits on the motor symptoms in Parkinson's. But the question is, how dirty is it in terms of what other effects are people going to get on some of the non-motor symptoms, their cognition, even some of their motor symptoms like balance, things like anxiety. We don't really know, and so I think that there probably is a right person and a wrong person for cannabis, but certainly more research needs to be done to figure out what all these effects are, and ideally hone the benefits of cannabis to specifically those receptors where we think that they would be beneficial, without the side effects that you would get from all the other receptors that we have for cannabis in our brains. But you're right, dosage and strain are a big issue there as well.
Right. And Dr. Lori Michelet, a lot of questions coming in about magnesium. What can you tell us about that?
Well, I think there's a lot of research out there showing that magnesium is low magnesium is one of the more prevalent nutrient deficiencies in America. The more coffee and alcohol you drink, the more likely you are to be lower in magnesium, because these are both diuretics. So I have, in my experience, found a lot of people to say that magnesium will help leg cramps and things like that. This is a bit of a curveball, but even more important than magnesium, but they act very similarly in the brain, is lithium. One of the areas that I do research in is this idea of lithium deficiency. And lithium is an essential nutrient. It is not on the FDA list of required elements. We think of it as something we give very large doses for people with mental illness. But in reality, the human body does need to get a few milligrams a day from lithium in their food. And that is something that I have found to be quite helpful for patients with leg cramps and things like that. And it doesn't need to be high doses at all. 5, 20 milligrams can make a huge difference.
Questions about coconut oil and oils in general. What do we know, if anything, about that? Lori Michelet?
I think this is back to that nutrient density question and the breads and pastas and gluten thing. And I think what we're learning is that Parkinson's may, in fact, be in part a metabolic disease. About 4 or 5 years ago, we started referring to Alzheimer's disease as type 3 diabetes, as we started to realize that in Alzheimer's, the brain is simply not doing a good job effectively turning glucose to energy. And I think there's an emerging body of literature in Parkinson's disease that is saying the exact same thing, that when you give the body a whole bunch of carbs, it does not efficiently turn that to fuel. And if you reduce the carbohydrates and increase the healthy fats and proteins, that the brain becomes much more productive in terms of energy metabolism. So I don't think we have any official data on coconut oil, but I do think that this idea of reducing carbohydrates and increasing good healthy fats and proteins is probably a good strategy.
And Danny Vega, review again for us what healthy fats are and what kind of oils and fats are the better ones to have? Yeah,
I mean, I generally consider coconut oil and olive oil to be the better oils because they're richer in the omega-3 fatty acids and the phenols, which have antioxidant activity to them. So things like nuts and avocado, and then certainly fish like salmon and that have omega-3 fatty acids in them. These are the good oils. The bad oils are those partially hydrogenated oils. Those are the inflammation-producing oils.
Let's move on to our last slide as we begin to wrap up our conversation today and talk about the kinds of things that we still need to learn about all of this. And Gary Vallat, let me come back to you as we begin to think about all of the reasons why research is so difficult, and the need, and one of the issues we see at the very bottom is these very individualized regimens and effects. And you were saying before when we were talking about diet that it's hard to know exactly, what's working and how to separate cause and association and what the actual impact is of different things. But curious to get your advice to people perhaps who have been newly diagnosed, who are interested in pursuing. How do you go about tracking this? Because I know one thing you do is you really try to keep track of what's going on with you, and that seems like an important part of the research puzzle, just from a patient point of view, is figuring out how your body is responding. How do you track those things, and what would you suggest that others living with do in order to begin to figure out what works best?
Well, at the very beginning, before I started taking the carbidopa-levodopa, I kept track of my symptoms, and I had 12 or 13 different items that were on that list. And I would check in every week or two, and then when I started to take carbidopa-levodopa, I could see very clearly that there was a significant and recognizable benefit. So I think personal logs, just trying to write down, Dr. Mishley has given me some forms that she uses, which are on half-hour intervals, and you just pick a scale from 1 to 10, and you identify a particular target symptom that you want to keep track of. I think the motion detector that I've been using gives you hard data, and I kind of like that, because if I can keep track on my personal, I keep a log that shows what time of the day that those things happen. So, I understand that there's apps now for cell phones that can measure your movement. I'm not sure that it's able to actually parse out what are the tremors from other body movements. But I just happen to have a proclivity towards data, and I like being able to look at it. But I will have to confess that I find it very difficult to subjectively evaluate my condition. If you were to ask me, are your tremors worse this week than they were last week, I'd have a very hard time answering that question. So if I can come up with some kind of measure that at least gives me an estimated thing, it's more beneficial for me in terms of evaluating the efficacy of the treatment that I'm involved in.
It's a terrific point. Yeah, no, it really does, and I think it points to it's a big question across all forms of treatment, really, and it points to this question that each of you have alluded to, that the more data we can collect, the better ways in which we'll be able to tease out perhaps some of these subtler effects, especially in a disease that's so varied, and it points to one of the research challenges before us. Another one, which is at the top of this list that I think is important to at least note, and it's something I'll call upon you to do if you would, Lori Mishley, is, it's hard to get research sponsored if there's no profit involved. Unlike some of the more pharmaceutical approaches, pharmaceutical companies have a big interest in researching those because it's a way that profit can be garnered. There's less obvious profit in coconut oil or whatever it happens to be, right?
Yeah, there are federal and international law that says you can't patent a naturally occurring molecule, and the recent numbers suggest that it takes about $1.2 billion to bring a central nervous system disease to market. That's about 40% higher than other drugs. And so if you can't patent your therapeutic, you have no reason to invest that kind of money. You won't see a return on investment. And it's just one of the things we have to contend with. We have to rely on foundations and National Institutes of Health and funding like that in order to move this forward.
And Danny Bega, as we bring our hour to a close, and then I'll go to you for a last thought, Gary Vallet, where would you like to see this field go next? What is it that you would like to see us concentrate, I guess, in the research community so that we have that much more data to support some of these, I will call them, I guess, additional approaches to living with Parkinson's?
Yeah, I think this is clearly such an interesting and important area because patients are demanding answers, and they really, patients are demanding better treatment options and more options. And physicians, first of all, need to be more open-minded in general, because there's a lot of resistance is just based on lack of knowledge. And like I said at the very beginning, these are a lot of things that we don't learn about in medical school. And so when we don't know something, we tend to automatically not invest our time and our energy into it. So time and energy on the side of physicians and researchers needs to be there, and it has been growing over the years. But then, organizations like Michael J. Fox and other organizations that fund this kind of research are around, and also the National Institute of Health does have a group funding some of this sort of research. But we need better studies. I mean, the one way to turn the heads of more doctors and researchers is to actually have studies that are well designed, as well designed as with conventional medicines, and we really are lacking in that. And that means particularly really good placebo controls, because a lot of people will say, oh, well, of course going and doing yoga or doing Tai Chi or doing anything is going to be beneficial, because doing anything is better than doing nothing. So how do we know that this particular intervention actually does something? So you really need well-designed trials by people who understand how to design trials before people will really turn their heads and understand what's going on.
And as we wrap things up, I just want to come back to you, Gary Vallet, for a last word about you're someone who does a lot. You're involved in a lot of things. And while on the one hand that may make it difficult to tease out, which it is that's actually making the biggest difference, would you say in the end that that's what is central to living well with this disease, is to be engaged, is to be involved, is to take an active interest in what works best for you?
Yeah, well, I would like to say that I think that that's important, but everybody, people are different, and the disease presents itself differently in different individuals. So I think, from my point of view, I'd be reluctant to say that try this regimen and you'll definitely see results. I know for myself that having that sort of outward point is important, and that my own involvement in community, although sometimes it gets out of hand, I get a little carried away, and I have to. My wife helps me come back down to earth. So I think it's really important to have a good caregiver involved. That certainly is an important piece for me, and to look for opportunities in community where I can be of service, or I can find involvement that matches my particular talents, and, where there's a need. So yeah, I tend to believe that exercise, that sports for me, ping pong. I changed the kind of sports that I'm doing, but the meditation is an important piece of the practice. So all of those things are beneficial, and I tend to think they'd be beneficial for others, but I'd be reluctant to encourage anybody. I'd say talk to your healthcare provider and work out a program.
Well put. And Gary Vallet, thanks for being a great example and role model for many of us to follow in the way in which you have approached this. I want to thank not only Gary, but Drs. Bega and Mishley for their participation in our webinar today. We'll be sending a link to the webinar so that you can listen again and share this with others. We'll also be sending out a survey link in that email so that you can give us your feedback so that we can continue to craft and improve our presentations in the future. And again, you'll be able to download these slides and some additional background information, including guidelines in terms of diet and nutrition, which we hope you'll find helpful as well. Please mark your calendars for our next Third Thursday webinar, which will be on June the 18th at 12 Eastern. We're going to be taking up the topic of speech and swallowing and how that's impacted by Parkinson's disease. That's June the 18th. And